Good afternoon. Thank you for joining the Kentucky SOS team for our monthly webinar. I'm Stacy Allen, a pharmacy consultant on the Kentucky SOS team, and I am joined by Emily Henderson, pharmacy consultant and project manager for Kentucky SOS. Today we have with us Dr. Connie White, retired obstetrician gynecologist. We will be discussing the use of opioids in uncomplicated vaginal deliveries, which is related to the Kentucky SOS metric 4B. This metric has been proposed to be included in the 2023 HRIP quality measures and thus have funding associated. It is for this reason Dr. White is speaking today. Specifically, the description of metric 4B is patients 18 years or older prescribed no Schedule II opioid after select surgical procedures. At the conclusion of the presentation, we will be able to recognize the leading causes of maternal death in Kentucky, discuss alternative treatment of postpartum patients to manage their array of pain, and identify ways your institution can inform patients of treatment options and expectations. We ask that you please type your name, credentials, and which facility you are with in the chat box so we have a record of your attendance today. As a reminder, the lines will be muted throughout the entire presentation. If you have any questions, please enter those in the chat box and Dr. White will address at the conclusion. You may also unmute your line and ask questions of Dr. White once she has concluded. The webinar will be recorded and posted to the Kentucky SOS website at www.kentuckysos.com. Be sure to spell out the name Kentucky, where it will also be found under the Events and Education tab. It is my pleasure to introduce Dr. Connie White. Dr. White completed medical school training at the University of Kentucky and obstetrics and gynecology residency from the University of Louisville. She is board certified in OB gynecology by the American Board of Obstetrics and Gynecology and the American College of OB-GYN ACOG District Public Health Chair. Dr. White practiced OB-GYN in Frankfort, Kentucky for over 20 years. She retired from clinical medicine in 2009 and became Division of Women's Health Director in the Department for Public Health before moving to the College of Public Health at the University of Kentucky in 2011 as faculty in the Department for Health Behavior. Dr. White returned to Kentucky Department for Public Health as Deputy Commissioner of Clinical Affairs in 2011. She is principal investigator for multiple grants that include chronic diseases to substance use disorder and works in the state pandemic response. She is the medical advisory to the Kentucky Perinatal Quality Collaborative. Welcome, Dr. White. We appreciate your time as you share your knowledge and patient experiences with us. And I will now turn it over to you, Dr. White.
Thank you so much, Stacy. I didn't mean for you to have to read all that stuff. That's so embarrassing. You know, it's like the only person that really does that is your mom. Speaking of my mother, she just got out of the hospital. She's sitting right over there. I'm in her kitchen. These are all baby pictures of me down the Hall of Fame, I call it. So you can appreciate my parents built this house in 1960 and my mom's at 93 and is living here by herself. So that's why I'm here. So if I just suddenly disappear, something has happened, but I think we're good for the next hour. And I'm going to turn my camera off just because I like the picture a whole lot better than what you're seeing today. We've had quite the weekend. So I'm going to, and in the introduction and looking over the objectives, I realized that I have actually left some slides out. So I have sent, oh goodness, y'all definitely don't want to see all that. I have sent Stacy the PowerPoint, but I'm going to send her an upgraded version that's going to have everything on it that she'll need. So I'll have to, in the middle of this, stop just a second and apologize because there's a place that there should be some slides that they aren't there. But I am so thrilled thrilled that you have asked me to come today. This is a topic, as Stacy said, I practiced OB/GYN for 20 years in Frankfort, Kentucky. I did it solo for 3 years, which made me a crazy woman. And then I got partners and spent 20 years and loved every minute of it before I came here to the State Department for Public Health. As I became more involved in the opioid crisis, because I did my last clinical medicine was in 2009. And in Frankfurt, at least, we did not have the type of issues that you see with opioids as we do now. So I was not really very savvy about this and how you deal with clinical medicine. So I have learned a lot. The first thing that, and before we even move on, I want to thank SOS and thank them for the ED Bridge Clinic work that y'all are doing. I know Dr. Marks was just here a couple of, either last month or the month before. I work with the CORE, the Kentucky Opioid Response Effort, and we are thrilled to see the expansion of the work that's going to be happening in the emergency departments as we deal with people who come in with overdoses and how we can use those opportunities to help them and not miss a chance to make that intervention. So my talk of it today, though, is about pain management and prescribing to the postpartum patient. The thing that got me interested, and this is an old study, and usually if I'm in a meeting and people are giving me 2017 information, I kind of do a little eye roll and say, well, that's old. But this prompted me to start thinking about what was happening in Kentucky. This was a study they did at Vanderbilt, where they looked at the women that were discharged home from the hospital with opioids, and then they surveyed them 6 weeks later and asked them, how many opioids did you use? Did you get a refill? How many were left over? Where do you store them? Are they in a locked location? And they found by doing this, and it was only 246 patients, but they found that there were the equivalent to 2,541 unused Oxy 5s just out there in the Nashville area. Most of them were unsecured, available for someone to steal, someone to share with others, because and most of the women said, I didn't need all of that pain medicine. So I asked Dr. Adam Baronis, who is our epidemiologist for our CASPR program, let's look at prescribing. Well, and let me take that back. It's not prescribing we can look at in CASPR. In CASPR, we're looking at dispensed medication. So we don't know, at least back when we started doing this, we didn't have electronic health records that looked at what was being prescribed electronically to pharmacies. We were just looking at what was being prescribed and dispensed to people. And I was hoping that in Kentucky, our providers were very savvy about this and were doing a great job, and we could see very low numbers of prescribing. As we were doing that work, this data came out from the American College of Surgeons, where they worked with Johns Hopkins, and they looked at a whole host of different medical procedures, 20 medical procedures, to determine what was the minimum number of opioid tablets that should be prescribed for these 20 surgical procedures. And the conclusion that they came to was that for many of these procedures, prescribing opioids was absolutely not the best the best treatment plan. And they looked at, okay, that slide didn't make it in. They looked at uncomplicated vaginal delivery, and in that uncomplicated vaginal delivery, they recommended 0 opioids for a woman who was not having any major complications, who came in, had a vaginal delivery. And so that was kind of the premise that we went with when we were looking at our data. We also wanted to look at and talk about today perinatal mental health challenges. There is a program called Lifeline for Moms. They just this last week released their perinatal toolkit. And I think as we're looking at pain prescribing, we also need to figure that the mental health challenges that these patients are facing. And we'll talk a little bit more about that later. But we know some of the most complicating factors for a patient in their pregnancy and during their first year postpartum are mental health challenges. There's the maternal aspect, the obstetrical aspect, and they're listed here: family outcomes, their partner, the offspring, and then the mental health disorders that are underdiagnosed, untreated, or undertreated. We'll talk about what the Kentucky Perinatal Quality Collaborative and the Kentucky section of ACOG is beginning to do to try to work on this. But all of these things are affecting the kind of pain that these women are having after delivery. Here's my slide that I thought I had left out. This is the list. This is the panel, and they went through all of these 20 procedures. I don't know if I got all of them on this slide, but this was their range, the minimum to maximum that they recommended for these procedures. And uncomplicated vaginal delivery was 0, and uncomplicated C-section was 0 to 10. The number of OxyContin 5 that were recommended for opioid naive patients. So we decided to look at our patients in Kentucky, and we wanted to look at that CASPR data. So Dr. Barones looked at our Office of Vital Statistics, and he looked at Kentucky residents only. And he looked then at women who had a vaginal or C-section, first baby, uncomplicated, no transfusions, perineal lacerations, no ruptured uterus, trip to the OR, hysterectomy, ICU admissions, nothing complicated at all. And then he matched them with CASPR to see how many opioids were these patients getting filled within the first 7 days after delivery. And many of you have heard me talk, have seen this before, but this shows that, so 2017 was when I read this article and asked Dr. Barones to look at this. So you can see in 2017, we really hadn't seen hardly any change. After 2017, it's more in the literature, it's more talked about. We have seen a drop. Not to the drop, we're still in 2019 and 2020, I don't have on this slide, but it's very similar. We're still prescribing on average in the first we're still dispensing on average in the first 7 days after an uncomplicated vaginal delivery, 35 MMEs to these uncomplicated patients, which I think if you compare this number to what the Johns Hopkins study is showing, this is extremely high. When I was in practice, and I know there's some eye rolling going on out there because I know that's what I would have done when I was younger, when I heard the old guys, and they were mostly guys, say, well, back when I was in practice, but back when I was in practice, we didn't give opioids to people for uncomplicated vaginal deliveries because intuitively to me, prescribing something that was going to make you dizzy and constipated just didn't sound like a good thing to go home with a medication that was going to cause that. And between when I've stopped practicing and now, that pendulum has swung all the way up to 45 MMEs, and we're seeing a downward trend. And that's why we're talking about this today, so all of you are aware of this. We took the data that Dr. Barones pulled together, and this is every birthing hospital in Kentucky. The shade determines how many deliveries that hospital does. So some of them do more, some of them do less, but the bar shows you what the average MME for C-section, this is C-sections and spontaneous vaginal delivery, is for that particular hospital. If you take all of them, the average was 49.1. So here's where we are, 49.1. We have some hospitals that were in the 72.3, 72.2 range. If you just look at vaginal deliveries, spontaneous vaginal deliveries, our average MME for this group was 41.6. That's what the blue line shows you. Some of the hospitals, those vaginal deliveries, even though 20.7 is not what we would expect for spontaneous uncomplicated vaginal deliveries, that was the best we had, but we still had some 64 and 63 for the average MME for their vaginal deliveries. This is looking at cesarean sections, and this is where we see those 73s, 73s, 64s, over 50, an average of over 50 MMEs for our hospitals prescribing to women with C-sections. So we do know that when patients are exposed to opioids, especially if they're opioid naive, you are going to have a certain percentage of these opioid naive women who will begin to have more, will begin to become either misuse or actually have a substance use disorder after being exposed. So what we wanted to do was kind of look at that. And unfortunately, Dr. Baronis left DPH before we finished the whole time. But I want to show you, it's a very busy slide. Don't try to look at this and understand this. But I'm going to pull out a few things to show you. This is from 2014 to 2017. These patients are opioid naive, which means no opioids prescribed in the last 12 months. We can look back at Casper and see that. And what he found was that 78% of our C-sections and our vaginal deliveries, 78% of our patients were opioid naive. That's really good to note that. You're looking at, if you add all of those together, that's 32,900 vaginal deliveries. If a small percentage of 32,900 vaginal deliveries, though, began to misuse or be addicted to opioids, that's still more people than we need to be exposing to this. Another way to look at this is I did this table where I took all of our years through 2020 and I wrote down the percent of the patients that actually got a prescription filled. So I thought it was interesting. In 2014, 34% of the patients who delivered vaginally, again, this is first baby, no complications at all, just came in and had a baby vaginally, 34% of them got a prescription filled. And in 2020, only 15% of them got a prescription filled. And I've talked to many patients who have said, well, they gave me a prescription, but I was scared of that stuff and I didn't think I needed it, so I didn't get that prescription filled. You can see over time that the total number of pills dropped a bit. Average daily supply stayed about the same, one pill different. And the MME, though, did drop 10%. Or 10 points in that 6-year period of time. Another way, a little bit better way to look at this is the light blue. These are the percentage of patients that filled a prescription if they had a cesarean section. And trust me, if I've done my share of cesarean sections. If someone did a C-section on me, I would want some opioids to take home with me. But I think it's interesting to see the dark line, and you can see how that percentage of getting a prescription filled really did drop over that time. I think our patients are beginning to read the news and talk to their friends and talk to their family and be much more concerned and respectful of getting those prescriptions filled. And remember earlier when I said, remember this 51 MME a day was the average for our cesarean sections. This is a CDC slide, and I didn't give them credit for that, but dosages of 50 or more MMEs a day will increase the risk of overdose by at least 2 times that of less than 20 MME a day. And the reason that this is so important, and this is where I would put the slide, and I will put the slide and send it to Stacy so it can be in your permanent slide deck collection. But we do know from our Maternal Mortality Review Committee here at the state that over 50% of our maternal mortality comes from substance use disorder factor. And I think I've presented that at this group before, but I just don't think we can say that enough. It's not hemorrhage, it's not stroke, it's not sepsis. In fact, only 16 to 20% of our maternal deaths are pregnancy related with those type of medical conditions I just listed. 53% of them are substance use disorder factor. All of the rest of that, over the 16%, are some kind of a social determinants of health, mental health type of a situation that led to the death of that young patient. So I think for us in the healthcare field, you've seen the numbers going down, but I think it's really important that we make sure that we're doing our piece and our part. So what we at the state have done is our office, our inspector general, have done some phone calls. If you think back to those waterfall slides, we've called a few of those higher level hospitals and pointed out to them that this is where you rank with other hospitals in the state, other birthing hospitals in Kentucky. This isn't national averages. This isn't what's happening in California or New York. This is your peers. And I think the CEOs were quite surprised. Interestingly, the nurses are sitting there, so because we would talk to the chief nurse and the CEO, and the nurses are nodding their head. They know what's going on, and they know who the higher prescribers are. CEOs seemed a bit surprised. We called these folks back within 6 to 8 months to see where they are, because we wanted to offer some help if they needed it. And what we found was within 6 months, everybody had cut their prescribing in half and were in the process of going down. Lots of our hospital systems are making big efforts now that we can look at medical records and know Dr. White is prescribing this many pills, Dr. Scott's prescribing this many pills, Dr. Kenner's prescribing this many pills. Those are my former partners, so those where those names came from. But hospital systems are beginning to see, and I just applaud the work that you're doing, because this is important. If you want to know how much 50 MME is a day, what I didn't know, and when we first started talking about this, well, what does that mean? Well, that would be a 10 of the hydrocodone and acetaminophen a day, 215 oxys, or methadone. This is another CDC slide. I don't think many people use methadone for their pain management. So when we talk to physicians, and I know when we had our OB staff meetings, and they would always pass out the numbers of who, this particular doctor who had a code had this many C-sections, and this one had this many C-sections, and we were always comparing to each other. Once we saw that data, it was really helpful, at least for me, in making those clinical decisions and how I compared with others. And I think when we pointed this out to those CEOs, and that came to their attention, and their quality improvement folks' attention, and their nursing staff's attention, it's something that we're thinking, oh, this is an issue. The Office of the Inspector General has looked at who are the biggest prescribers and wanted to have one of their on-staff pharmacologists talk to the biggest prescriber that we had in Kentucky. It turns out the biggest prescriber of postpartum opioids in the state of Kentucky was an APRN. Not a certified nurse midwife, but an APRN. Well, this made no sense at all. So that's why we wanted to talk with this woman. And what we found out was that this APRN was a prescriber at one of the biggest OB practices in one of our larger settings. And her job was to discharge everybody. And she was instructed that if you had a vaginal delivery, you got this many pills. And if you had a C-section, you got this many pills. There wasn't any going back looking at the hospital record to see how many pills that you had taken while you were in the hospital. No conversation with the patient. It was Connie White had a C-section. She gets 35 pills, and Deb Colston had a vaginal delivery, and she gets 20 pills. When we talked to her and then talked to her practice and made them understand this data that y'all are looking at, the Maternal Mortality Review Committee data, they're making a change in that very large practice. And so that's what we're trying to do. We're, when you get the Office of the Inspector General involved, that makes people a bit nervous. And Adam was very clear to be sure that people understood we're not doing this to be punitive. We want to make sure everybody knows their data, that they're looking at their data, and they're trying to understand what are we doing and how can we do this better. So one of the questions that Stacy had for me is, what can we do besides opioids? I mean, I've heard many of my ER friends say opioids in the ER is the easy button. Somebody comes in, you give them a prescription, you hit the easy button, and you they're out the door. I did a breakout session with at the National OBGYN meeting probably 5 years ago, and we were talking about this very topic, and I almost fell off my chair when I had residents telling me that the average number of prescription opioids they gave for a C-section was 45, and for vaginal delivery was 35. And I looked at them with my mouth open and said, why would you prescribe such a large number of pills? And it was, well, my chief resident told me that. That's what we do. That's our culture here. And when I tried to back off one time, the nurse came in and said, why did Dr. White not give you enough pain pills? Does Dr. White not like you? I mean, it was a whole labor and delivery setting of, this is what you do. You send people home with opioids. And I'm so encouraged to see that wave, that whole culture changing as we look at this. So we know that that if we look at patients who are getting an opioid and they're opioid naive, if they get those pills for more than 5 days, that chance of a substance use disorder or misuse goes up. So everything we can do to give patient pain relief, nobody wants people to go home hurting, but to be sure that we give them alternatives. And I think that's our next step that we need to perfect as we go through this whole dance of how do we care for our patients? How do we make them understand that we want the best for them, but also that we don't send them home hurting. So this is this just came out a year and a half ago from ACOG, and it's a really good read. I say that because I'm a public health nerdy kind of person, but it is a good read, and it's I don't remember how many pages long it is, but it goes through in detail all the things that we can do, that we can offer to our patients, that we can allow them to understand that we want to individualize for them what kind of help that we can offer them that will get them through this time. And I think time is one of the things that's mentioned in here. Is this is time limited. This postpartum pain discomfort is going to be time limited. And you know, some people who come in and have a baby and don't even take a Tylenol because they just have a different pain threshold than the patient that comes in and has a lot of trouble, especially those that have 3rd and 4th degree episiotomies, that have hemorrhoids, that have labored a long time, plus the other complications, vaginal wall hematomas, and there are a host of things that do cause pain. But I think being sure that the patient understands this is time limited, that really helps you to be able to tolerate this, I think, quite a bit better. I think we need to talk about the self-help treatments and the over-the-counter things that are available to them. Some of them sound kind of old-fashioned and old-timey, but back in the olden days when your grandmother lived next door and Aunt Susie lived on the other side of the house, and they knew all the things to tell you to do. Patients don't often have the luxury of that close family, those close connections. And so they're kind of at a loss as to what to do. But I think we want to be sure that we let them know we want to take care of them, but we also want them to be able to take care of that brand new baby. That time of bonding is so critical. And if they are on pain medication and they are sleepy, they're going to miss a lot of that early experience. And if you've ever heard my adverse childhood experience presentation, you'll understand, and you probably intuitively know that those early days and hours of bonding with that caregiver is so critical to laying down those neural pathways for that baby. So this document goes through in detail ibuprofen and Tylenol. They're certainly my go-to right now for my rheumatoid arthritis, but ibuprofen and Tylenol given alternatively do an awful lot of help for the kind of pain that these patients have. But we don't want to forget things like a heating pad. A heating pad has gotten a lot of us through a lot of things when we were growing up in our teen years. And I've had patients that have sworn by this. I even saw an article the other day about how therapeutic hot water bottles are and how the hot water bottle was so helpful for them for a whole host of things. Ice packs and cold gels, especially in the perineal area, for no more than 10 to 20 minutes at a time. But if we can get the swelling down, the pain is so often swelling in that area. And any swelling, it's kind of like swelling around your eye. There may not be much swelling, but you've got so many nerve endings up there that it is exquisitely painful. Same happens in the vulvar area. So if we can get ice packs and cold gel packs to help with that swelling, that's going to be comforting for the patient as well as keeping the edema down. The witch hazel pads, I never use those, but they're mentioned in this article. That is a very helpful, again, to work with the swelling. And then the sitz bath. I think everybody should go home with a sitz bath from the hospital, whether you have an episiotomy or not. That ability to keep yourself cleaned off and feel clean and feel fresh and feel that comfort of that warm water, it makes a huge difference. Pillow supports, man, those donut pillows are worth their weight in gold. Making sure that your patient understands if there's hemorrhoid issues, if there's swelling issues from that vaginal delivery, that she's got that to sit on. And don't forget your C-section patients that went through a lot of labor. A lot of them will have a lot of vulvar edema. And I think we focus on checking out that incision, making sure the incision's okay, talking to them about management of that incision. We forget that some of them are going to have perineal edema. They're going to have discomfort. We don't want to forget to provide them with the help that they need. Stool softeners, we always, well, no, I won't tell you that. That involves a name brand, and that's probably inappropriate. But stool softeners are important because constipation is, and usually constipation, for you've never done a vaginal delivery, there's a lot of stool that comes out with delivery of a baby. So there's not going to be a bowel movement the first day or two. But when that happens, we want to be sure that that is not a painful and hard experience for that patient. So getting them on those stool and explaining to them, because a lot of my patients would say, oh, I don't need this. Trying for them to understand this is prophylactic, this is trying to help as we go down the line. Numbing spray. This is also mentioned in this ACOG article, where you can do some different Novocaine type sprays that can be very helpful for patients, maybe not to use every minute of every day, but if they're trying to go through an experience where they know they're going to be in the car going somewhere, or they're going to be in some type of an experience where that would be helpful for that short period of time, numbing sprays are a good option. Abdominal binders. I think those are wonderful. I haven't had a major abdominal procedure myself since I was a kid, but patients swore by their abdominal binders. Some wore abdominal binders, those under the belly binders that help hold the uterus up off the pubic symphysis, but these are abdominal binders that hold the abdomen still, so that when you sneeze or cough or smile or laugh or get up out of a chair or whatever you do that puts strain on that abdomen, those abdominal binders, and most hospitals have them. We need to offer them and I think encourage them. That's very important. The other thing that we sometimes forget about, although again, this is much more prevalent now than when I was in practice 10 years ago, are your lactation consultants. Because if you've had a cesarean section, sometime getting that baby positioned in the right way is very uncomfortable. So how can we position that baby to be sure we have a good latch on, but not cause pain in the abdomen? It would be a shame if that was what was preventing the mom and baby bond, for them to be able to do that lactation, that good, powerful lactation that the patient needs. In this clinical consensus, they have, as any good clinical consensus will, they've got a really nice algorithm that I thought might be helpful. I think, as I said before, we need to talk to our providers, our nurse midwives, and our obstetricians and our family practice doctors that are doing the doing the discharge instructions. But this just goes right through, starting with the ibuprofen and the acetaminophen. If the pain is continuing and they're breastfeeding, then you go yes, no. What are you going to prescribe? On the vaginal delivery arm on the left, the last thing you're going to try to do is that low potency opioid as needed. And then try to limit that duration. On the C-section side on the right, going through the same kind of an algorithm. One thing that I did was, when I did prescribe my opioids, I don't know where I came up with the number 12. There's no double-blind placebo-controlled trial on that. I just would write a prescription for 12 and no more than that. And when I handed the prescription to the patient, I would tell them, if you need more than this, you need to call me, because I want to be sure that there's not some complication making you hurt more than I am expecting you to hurt. And I think in the 20 years that I did this, I probably had 1 or 2 patients call. One of them, unfortunately, was because she and her husband had had sex within 6 days after delivery, and she had some problems from that. But most of the time, if patients have an expectation that 12 is all I'm going to need, they pace those with their ibuprofen, with their acetaminophen, and that gets them to the point that they're not in that kind of pain that's not manageable with these other kind of alternative treatments. This is something that I found when I was looking up some information for this presentation that I thought was really, really quite good. ACOG has a lot of information. I know you have to pay for it, so I'm not here. I'm not employed by ACOG. I'm not trying to push their materials, but this is just a screenshot. But if you click on this, it's going to answer all of these questions for the patient. I think we sometimes think they know these things intuitively. And having just brought my mother home from the hospital yesterday, and the nurse was trying to give me discharge instructions, and we'd been waiting 5 hours to go home. It was 7 o'clock at night. My mother was tired. I just signed every page and said, great, sure, I'll read this later, because I was trying to get out of the building. So I think when we say, here's your discharge instructions, and if you've ever seen the Charlie Brown specials, whenever the teacher talks, it's wonk, wonk, wonk. That's what the teacher sounds like to the kids. And so I think that's what we sound like when we say, you can go home today, here are your instructions. They're hearing the wonk, 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 and not really hearing, even if you're careful in how you describe these. So I would go on the website. Actually, there's a print right here, so maybe they don't charge you for this anymore. I don't know. But I would definitely look at this, because I think the more information we can send people home with, the more we give them reasonable expectations, I think the patient and the provider is going to be much more satisfied that we're just not sending them out there to fend for themselves. Because if you don't give them instructions, you know what they're going to do next. They're going to be Googling it. And even when I was in practice, as many years ago as it was, I spent almost as much time trying to talk people out of what they had read on the internet as I did trying to explain to them what I was trying to explain to them. When a 27-year-old comes in with 20 pages of printed material saying, I have uterine cancer because I'm bleeding, at 27, that's probably not why she's bleeding. It probably has a bunch of the new birth control pills she just started on. So you have to kind of talk them off the ceiling and say, no, I don't really think this is your problem. I think this is your problem for these reasons. So if we can send them home with a document like this from the postpartum pain management, or whatever document your providers may have come up with, your own, your hospital may have your own, but I think sending them home with some reasonable expectations is the key. One of my mother's hospitalizations at a large university hospital, they they asked the usual questions. What's your pain level? And she said 6. And then the nurse said, what do you expect to go home on? What pain level do you expect to go home with? And my mother said, well, I can handle a 4. And I asked the nurse why she asked that question. And she said, when I have someone who's coming in and they're having a hip replacement and they tell me they're expecting to go home with a pain level of 0, I know right off we've got some expectations we need to meet, and we need to change the way before we even do the surgery for them to understand this is a painful procedure. We will manage your pain. We will not erase your pain, which I thought was a really, really interesting way to approach that. So I'm going to come off of this right now and be available for questions. I would love to hear what some of you are doing. Like I said, we've talked to different hospital systems and we've learned so many great things that folks are doing. The Kentucky Perinatal Quality Collaborative, which some of you are involved in, we are working right now with a group that has a group of OB anesthesiologists that have come up with some great protocols for pain management for people with substance use disorder. Many of these women come to the hospital and they're looked at and told, you've got a substance use disorder, we're not going to give you anything for pain. That's not advisable. And we're trying to give hospitals kind of a template or something they can follow, so ways that they can allow these women to get the pain control that they need. But I would love to hear what other people are doing right now for this kind of work. How are you managing the pain of your postpartum patients? And it would be great if we could pull all of those together, and if it's not priority information by your hospital system, so that those out there who don't have something already set up could have that as a template to go by. Because sitting down with a blank piece of paper is always frightening. It always slows the process down, and it doesn't get you as quickly to what you need, because you want your patients to have the best they can have. That's why you get up every morning and go into the office, because you have a passion and a mission for these patients and their babies, and you want to make sure you're doing the best. And if you can hear from others, and like I said, that's what the Quality Collaborative tries to do. Let's pull all the quality work people are doing together in one place and share it, so we can all be doing that high quality work. Our mission statement for the Perinatal Quality Collaborative is Kentucky, let's make Kentucky a great place to have a baby and a great place for every baby to be born. And I think if we put our heads together, that will make it easier for us to do that. So Stacy or Deb, do we have questions?
I have a quick question, Connie.
Hi.
What kind of, hi, how are you? What kind of barriers have you seen to physicians or providers and the patients to accept the safer opioid practices?
Well, I think it even starts, and I was talking about the docs, or the nurse when the patient came into the hospital, giving some expectations. I think we need to go even a step backward, a little step further back. When people first come into their care, I'm assuming that at least what I did was I talked to people about pain control while you were in labor. What I didn't talk to them about was pain control when they went home, because it to me seemed pretty intuitively obvious, and we didn't have an opioid problem in Frankfurt at that time, and so it wasn't a thing. But I think the more we can set their expectations as having a baby is uncomfortable or hurts, depending on where you are in that spectrum, and making sure that they see that you are trying to let them be the best mom they can be, the best parent that they can be, the best caregiver they can be, and we're trying to protect them from any future substance use disorder. It's very rare. If we could do it anonymously, I'm looking at 51 people right now. All of you know someone, and it may be closer than you would like to admit, that have substance use disorder. It was interesting when we looked at some of our higher prescribing hospitals, they were in the urban areas, where some of our rural Eastern Kentucky areas were where the fewer pills were prescribed. And this was when we first looked back in 2017, because the people in Eastern Kentucky have lived this longer than the rest of us have. And they had already figured out that this was not a good idea. So it's a conversation, Dr. Connors, and I think you just have to put that expectation. I'm not trying to deprive you of anything. I'm trying to support you. And that's a balance you have to, in that trust that you have with your patient population.
Thank you.
Connie, it's Deb. I have a question about when we say uncomplicated delivery, is there kind of I recognize that could be somewhat subjective, but what do you think of when you think of that? I'm personally would I feel like if it happens to me, it's complicated. So how would you help a clinician kind of figure that out?
Well, I was always amazed when after a long delivery and I'm sewing up the episiotomy and the mom's laying there holding this baby and they'd look up at their coach and go, "Oh, that wasn't so bad, was it?" And I'm like, "Man, it looked pretty bad to me," you know. But so in this particular work that Dr. Barones did, he called uncomplicated vaginal deliveries as no maternal, I'm looking at my phone because I've got the slides on here. No maternal transfusions, no perineal lacerations, no ruptured uterus, unplanned hysterectomy, unplanned OR procedure, or ICU admission. So he used those qualifiers and first-time moms. So that waterfall chart and that graph that showed the number of MMEs going down were all completely uncomplicated vaginal deliveries. Now, there's one hospital system that has taken that, they've looked at all of their deliveries. So they didn't just look at the uncomplicated. I was hopeful that if we showed that even in these, pristine, come in, had a baby and went home, we were still giving high doses of opioids, much higher than I couldn't even, I shuddered to think about what those other moms were getting. So there are some hospital systems that are looking at this data now, and they're going to share that with us. And so we're hopeful to hire a replacement for Dr. Barones soon so we can expand there, because with Casper, we have a wealth of data if we can just figure out how to massage it and how then to give it back to the birthing hospitals so they can use that information as well. They know what they've prescribed. We know what's been dispensed. Nobody knows what's been taken. But at least we can make that step from hospital X says we prescribe this many pills. Casper said this many pills were actually dispensed. That'll help us to understand, are we like in that study at Vanderbilt where most of the women said, "I didn't need all these pills. I didn't know what to do with them. They're in my medicine cabinet." That's frightening, because those pills, somebody's going to figure out how to use those pills, unfortunately, whether it's, cousin Ralph who comes by and suddenly the pills are gone, or I've heard of people showing their house at an open house and suddenly pain pills are gone from their medicine cabinet because some open house person decided they needed them. Or somebody breaks in your house and steals stuff. So getting those numbers down is critical, and it's not going to happen until we actually look at our data and go, I'm giving everybody 25 pills, but they're only taking 4. They took 3 in the hospital. Why am I sending them home with 25 pills? So, are there algorithms we can come up with in our medical records? And I know there are people that are working on that. So if I come in and Deb Campbell's going home today, I can hit a button and it's going to tell me Deb Campbell will need 12 pills to go home, or 4 pills. She took 4 in the hospital. So, or at least tell me how many pills she took in the hospital. So I can, as a clinician, make some kind of data-driven decision that if she took 4 pills 2 days postpartum, she doesn't need 30 to go home on. But you're right. If I had a vaginal delivery, it'd be a miracle, but it would be way complicated. And for all you moms out there, you're amazing.
Are you seeing the dispensing in your studies that it's mostly immediate acting as opposed to long acting opioids that are being prescribed?
That's a good question. I don't know the answer to that, but we can break it down by what pills were. And I think Dr. Barones looked at that, but I don't have a slide on that. So I need to look back on that. That's a great question. Is is it Tylenol 3? I said something about Tylenol 3 the other day, and there was a room full of physicians just laughed at me and says, nobody prescribes Tylenol 3 anymore. I was like, well, that was kind of my go-to pill because it was low. But I think, yeah, which pharmaceutical are we prescribing, as well as not just an opioid, but what opioid are we prescribing? We'll put you in the acknowledgements when we figure this out and publish that study. Thank you. I will let you know what our, two things that are going on, the Perinatal Quality Collaborative, because of Kentucky's #1 cause of death in our postpartum women being substance use disorder. We have just finished the first cohort of hospitals in Kentucky who have volunteered to do expert interventions on all of our moms that are coming to labor and delivery, and then making sure each of those 9 hospitals have resources in their local community to be sure that these women have a warm handoff. We're making sure they're going home with naloxone if there's someone in their family. I mean, I carry naloxone with me. When I change purses, and I think most of you on here are women, it was always the credit cards that went first. It's my naloxone first. I was in California visiting friends, and they were shocked that I had naloxone in my purse. And I said, I go nowhere without it. And so we finished those 9 hospitals. Now all the work they've done on the patient flow, trying to streamline everything, is going to our second cohort. And then we'll be able to spread that out statewide to show what kind of improvements this has made, because we feel like this is a great start. If we can do that in the labor and delivery setting and get that culture to kind of start thinking more about this, then we can move it back into the setting of while you're pregnant, and working with our providers to start asking these questions. I mean, labor and delivery is a little late to do this, but this was a great place for us to start, help that culture develop. And it's just been the labor and delivery staffs and the providers have just been marvelous to work with. And every hospital we went to, each one of them were doing something we'd never heard of, and the other hospitals hadn't heard of it. So that's like when I began, if we can get those best practices that this hospital's doing and share it with all the rest of them and share their best practice, because a lot of the hospitals we went to said, well, we don't have anything. We have no resources to send people to in our community. And they just didn't know it. So we're also working with Dr. Marks, who spoke on the ED Bridge Clinic. She's looking at the resource manuals from each of these hospitals to be sure there might not even be something else that they may have missed, because she knows the resources of everywhere. So we're working with other departments to help us and make sure that we're making sure that these patients, when they go home, have all the resources at their fingertips, and so that's been very helpful. So we're excited about the direction we're going. We're going to have a fall meeting, I hope, at Keeneland this fall. You'll be hearing about it. I'll send it to Stacy and Emily to get out to you guys, but we'll be able to let those hospitals present their data and show us what they've learned and what they're doing differently and how they managed to do it, how they kept their teams engaged, and how we got people on board to do these quality improvement programs. And Deb, do you want to do a commercial for our quality improvement lecture that we're doing? When is that? I don't want to say the date because I'll get it wrong.
March the 2nd.
Second.
Yes, I'd love to. Thank you, Connie, for giving me that opportunity. We have some winners of our quality awards who've done work in this space. So I think we have someone talking about hypertension. We have someone talking about the going to home program, and we have someone talking about hemorrhage, maternal hemorrhage. And Dr. White's going to lead off to give us kind of the state of the maternal health in Kentucky first, and then she will be leading that panel and letting them share with you their best practices. So another opportunity to hear about what others are doing. March 2nd at our quality conference. Everybody join us. We'd love that.
At the Campbell House.
At the Campbell House, right. No
Good.
relation.
Oh. I was saying that because I've done so many Zoom meetings that when there's an actual in-person meeting, it throws me off my game. It's like, oh, I have to drive there. Oh, okay.
I'm glad
And-
you said that, because I do forget that too. I'm so used to the Zoom. Thank you.
And wear nice shoes. Any other questions about what's happening state level? That's what I'm going to be talking about as our Maternal Mortality Review Committee. Oh, ACOG. We are looking at, Kentucky ACOG is working with us. There is a hotline called Lifeline for Moms, and this is a hotline for providers. So if Dr. Connors walks in 6 weeks postpartum and I look at her and go, holy moly, she needs some help, and I'm an obstetrician, that's not my swim lane, I don't know what to do. This is a hotline I can call and talk to a perinatal psychologist and talk with that person about how do I treat her, my patient in front of me. This has been very successful in Massachusetts. Indiana just started it, which breaks my heart that Indiana started something before we did, but we are working on getting that set up. It will be a while, but recognizing that when Dr. Judy Terrio, our medical director at Medicaid, we looked at all the postpartum admissions. So we looked at all the moms that had delivered in Medicaid, and 3 months postpartum, what was the number one reason for admission? And again, it wasn't hemorrhage or infection. The number one reason for being admitted was suicidal ideation, which to me was shocking, because when I was in practice, you practically had to have an axe in your hand or something to get admitted for suicidal ideation. I mean, it was hard to get that admission. It wasn't a large number of women, but that was the number one reason. And then under that were things like anxiety and depression. And so our moms are telling us this is what we need. So we need to, now that we've got that data, we need to start going in the direction of providing more postpartum care. And so postpartum mental health care. So I know that's the direction we're going to be going, that Medicaid is going to be going. And as being part of the Maternal Mortality Review Committee, we see this all the time. So I think you're going to see some new directions, and we're definitely going to need the KHA's help on this, so we can figure out how can we include what you do with what the providers do, with what every other availability, the Kentucky Moms Matter, all of the different ways that we can reach out to these patients once they're discharged.
Well, thank you, Dr. White. I don't see any more questions in the chat box at this time, but I just wanted to say thank you for another wonderful webinar that you've done for Kentucky SOS, and it's very apparent that you are passionate about women's health care. Thank you so much. Just as a reminder, Emily has placed in the chat box the Kentucky SOS website, along with my email and Emily Henderson's email if you all have any questions following the webinar, as well as Dr. White's email has been placed in there as well. I don't think that we have any more questions at this point. So again, thank you so much, Dr. White. Oh, we might have one more message. Let me double check. I'm so sorry.
It's just my email address that Emily put in.
Yep. Thank you.